Good afternoon.
Okay, time is up, almost up. And Dr. Khalid, you can turn on your sound, your voice, your microphone. It's mute.
Yeah, my mic is mute, so I can't use it.
Now it's okay.
Yeah.
Okay, so it's around, time is up. I think we can start our webinar. Okay. Okay, so hello everyone. How are you? This is Audi from Wisonic Medical in China. Welcome all the new and older friends to join the 19th global webinar of Wisonic Dandelion College. Wisonic Dandelion College is a free online platform for the purpose of sharing the cutting-edge know-how and insights of point-of-care ultrasound applications with global professionals and medical practitioners. Today, we are much honored to invite Dr. Hani Hariri from Saudi Arabia as our webinar speaker to share his valuable experience of point-of-care ultrasound integrated to septic shock management. Meanwhile, we are also much honored to invite Dr. Khalid Maghrabi as our webinar moderator. Today, the webinar will be divided into two major sessions. The first session is the speech by Dr. Hani. It takes about 15 minutes. And the second session is Q&A. Welcome you all to raise your questions and further communicate with Dr. Hani during Q&A sessions. Now, please allow me to give you a brief introduction of our webinar moderator, Dr. Khalid Maghrabi. Dr. Khalid Maghrabi, he is currently working as consultant critical care medicine in King Faisal Specialist Hospital and Research Center, Riyadh, Saudi Arabia. He has been the chairman of critical care medicine department in King Faisal Specialist Hospital and Research Center, Riyadh, since 2013 till 2020. He studied at King Abdul Aziz University and awarded as MBBCH. He is certified by Arab Board of Internal Medicine. He is certified by Saudi Board of Internal Medicine. He is a member of the Royal Colleges of Physicians of the United Kingdom. He completed the Fellowship of Critical Care at the University of Ottawa, Canada. He completed MBA International Health from Frankfurt School of Finance and Management, Germany. So let's welcome Dr. Khalid. Please, Dr. Khalid. Oh, you need to turn on your voice, microphone.
Thank you very much, Odi, for this nice introduction. And it's my pleasure to introduce today our speaker, Dr. Hani Hariri. Dr. Hani is a senior emergency medicine physician with almost 20 years experience. He studied University de French Comité France and awarded Doctorate of Medicine degree in 2001. He's an active member of the European Society of Emergency Medicine and accredited ultrasound senior instructor. And he's the founder of and a member of the French Network for Ethic and Pandemic in St. Louis Hospital, Paris. And he's a member of French Society of for Emergency Medicine, a member of French Society of Infectious Disease, and a member of the Global Network Emergency Medicine. And he's associate member of the World Interact Network focused on critical ultrasound, the WinFocus group. He's associate professor of emergency medicine in Al Faisal University College of Medicine, Riyadh, Saudi Arabia. And he's associated professor of emergency medicine in Al Faisal University. He's worked at King Faisal Specialist Hospital, Riyadh, in multiple positions since 2009. He gained experience in multiple fields as a consultant of emergency medicine and infectious disease since 2009. He's a member of Hospital Infection Control Committee since 2010. And he's a director of infection control in the Department of Emergency Medicine in the same hospital. And he is a director of point of care ultrasound since 2017. Dr. Hani was the chairman of the organizing committee of emergency medicine and critical care ultrasound workshop endorsed by the European Society for Emergency Medicine. He's active in this field, and today he will talk to us about a very important topic, which is integrating ultrasound in the management of sepsis, which is a very important topic for both critical care medicine and emergency medicine. Without further delay, I will leave the stage for Dr. Hani. And please, Dr. Hani.
Thank you.
Thank you very much, Dr. Khalid, for and I would like also to thank you for Mr. San, Odi, and Wisonic for giving me the opportunity to present this interesting topic. Point of care ultrasound integrated to septic shock management. As mentioned, Dr. Khalid, I'm working in King Faisal Specialist Hospital, one of the well-known tertiary care hospital in the Middle East. We have a lot of our patients are immunocompromised, oncology patient, post-chemotherapy, post-organ transplant, autoimmune disease, genetics, and those patients develop easily a lot of infectious complications, such sepsis and septic shock. And every day we are dealing with those patients. And I'm every day more and more strong believer that point of care ultrasound may improve patient care and save a life, especially with critically ill patient. And today I will try to share with you my experience with severe sepsis and septic shock patient. Before severe sepsis and septic shock, its major cause of death in the world, around 100,000 in USA every year, a lot of death everywhere in the world, huge burden. And while we diagnosed septic shock, even we are giving a prompt management, the mortality is still high, around 30%. And the economic cost is huge. We will give the example of USA, around 17 billion per year. We can compare severe sepsis to other disease like CHF, breast cancer, colon cancer, AIDS, and the incidence and the mortality. We can see how the incidence, it's overtaken all the other disease. And in this slide, this study in 2000 showing it's around near the mortality due to MI. But with this slide, we can see that the sepsis incidence and mortality are overtaken myocardial infection mortality. And it's increasing dramatically every year. It was increased 8 to 13% over the past decade. What's the reason? There is multiple reasons for that. The development of drug-resistant and more virulent varieties of pathogens, the aging society in developing world, malnutrition, poverty, lack of access to vaccine. Also, there is a problem, sepsis, it's not universally seen as medical emergency until the patient collapsed, became hypotensive, and we know as early as it's recognized as sepsis and we start a prompt management, the prognosis is better. Sepsis care is currently haphazard. There is a difficulty to be recognized everywhere. and the increasing number of invasive technique, heavy surgery, frequent use of immunosuppressive therapy. Hospital cost is huge, as I mentioned. And now let's go to quick definition. The old definition is what we said, SIRS, Systemic Inflammatory Response Syndrome, going with hypothermia less than 38 or less than 36, tachycardia less than 90, or tachypnea, respiratory rate less than 20, or leukocytosis or leukopenia associated with infection. We know we go to severe sepsis when we have organ failure, and septic shock when there is refractory hypotension. This is the old definition, which is the problem of SIRS. It's not specific at all, and any patient coming to the emergency can meet two of the following items regarding SIRS. Any patient with any endogenous stress. Now we are trying with a new definition of recent new definition of septic shock. Sepsis is considered a life-threatening organ dysfunction caused by a dysregulated host response to infection. And septic shock is sepsis with underlying circulatory and cellular versus metabolic abnormalities are profound enough to substantially increase mortality. Term like term of severe sepsis or septicemia was removed. And now with the new definition, we considered sepsis with Q-SOFA with two items, hypotension with systolic blood pressure less than 100, altered mental status with Glasgow Coma Scale less than 13, and tachypnea with respiratory rate more than 22, or raise in SOFA score by 2 or more. And we consider septic shock sepsis requiring vasopressors to maintain MAP more than 65 and lactate more than 2. How to improve sepsis management? Definitely start by early detection, accurate diagnosis, to start empirically large spectrum appropriate IV antibiotic, supportive care, including airway management, oxygenation, IV fluid therapy, and IV inotrope, blood sugar control, and low dose of steroid. To resume that, what is the role of point of care ultrasound in the management of sepsis and septic shock? I'm a strong believer that, as I mentioned before, that point of care ultrasound is powerful clinical tool for the management of sepsis and septic shock patient, for early recognition, to identify the potential source of infection associated with organ dysfunction, to guide fluid resuscitation, response to various intervention like a fluid challenge or administration of inotrope can be assessed at bedside with ultrasound, and definitely to enhance safety and increase the success of bedside procedure like central line cannulation or venous of pleural effusion. At the beginning, we need to know patient presented with shock. At the beginning, we don't know, is it septic shock? Is it anaphylactic shock? It's hypovolemic shock, cardiogenic shock? We don't know, and we will start from the beginning and differentiate shock. Patient with hypotensive, blood pressure, systolic blood pressure lower than 90. It is life-threatening condition, circulatory failure resulting to inadequate tissue perfusion, cellular hypoxia, and organ dysfunction with confusion, renal failure, hepatic failure, and the cause at the beginning is unclear. which kind? We have different protocol for scanning hypotensive and choked patient. The most used in the world is the RUSH protocol, rapid ultrasound for shock and hypotension. This RUSH for hypotension, we are dividing our assessment by 3 items: the pump, including the heart, cardiac assessment, and the assessment of IVC, tank, including the lung and abdomen, and pipes, aorta, and DVT. Check for aorta and DVT. We will start, we can start, however, we need to do it, the order doesn't matter, by doing cardiac assessment with, we have 4 window, parasternal short axis, long axis, apical 4-chamber view, and IVC to check for lung, the left ventricle function, if there is or no RV strain, if there is pericardial effusion or not, to check the IVC, is it if there is a change, there is IVC, non-compressible or not. About the lung, we can check for lung sliding, if there is or no pneumothorax. We can check if there is pleural effusion or not. We can check also for B-line at sign of interstitial pulmonary involvement, also abdomen, by checking right upper quadrant, left upper quadrant, and pelvis to check if there is any free fluid in the peritoneum, like related to bleeding, and also for the aorta, if the aorta is more than 3 centimeters, if there is a sign of dissection. And for DVT, we can check the femoral vein and popliteal vein, is it compressible or not. Starting by the beginning, the pump. As I mentioned, we can check the heart with parasternal long axis and short axis, then apical 4-chamber view. Also, we can use sometime subcostal view for IVC. We have all these different windows, 4-chamber view, we can see here, 2-chamber view in this one, parasternal short axis with the papillary muscles, and here the parasternal long axis. In the 4-chamber view, we can see here easily the left atrium, left ventricle, right ventricle, and the right atrium. In the parasternal long axis, we can see part of the left ventricle, of the right ventricle. This is the left ventricle, mitral valve, and aortic valve. We want to check if there is dysfunction in diastole or systole. We can see with this view. This is the LV. We can see how it's moving, how is the contractility of the heart, the global contractility of the heart. We can also estimate the fluid status of the patient. Now, for example, we can see here normokinetic heart in parasternal long axis, and here the other view, severely hypokinetic heart with very low ejection fraction. Patient could be hyper also. We can, heart ultrasound may help us to estimate the fluid status of the patient. And we can see here, we have dilated heart. This patient, he is obviously hypovolemic with dilated cavity. and the other one, clearly patient severely hypovolemic, and we can see here the wall of the both ventricle touching each other. We say that sign of left ventricle kissing sign. It's really a sign. This sign may help us. It's sign of severe hypovolemia. We can see also if there is pericardial effusion. Here there is massive pericardial effusion, we can see there. And this view also show us pericardial effusion. After assessing the heart, what we say, going to the tank, what we said, reservoir, where is we can go by doing checking the lung and checking, doing like FATS, right upper quadrant, left upper quadrant, subcostal view for IVC, and also the pelvic area. And the evaluation, this is the second part of RASH. We are checking the fullness of the tank with the inferior vena cava, leakness of the tank, if there is any free fluid, any bleeding, by doing fast and thoracic ultrasound, and if there is any compromise of the tank by the presence of pneumothorax. We assessed first the fullness of the tank. We are looking both to the relative vessel size and its respiratory dynamic, the respiratory change between inspiration and expiration of the IVC will provide us the indication of the intravascular volume, and it has been used to estimate also the central venous pressure. The image of IVC, the probe is placed in the standard 4-chamber sub-xiphoid view to first identify the right ventricle and the right atrium. We can see with this view where we can put the probe and how we can assess the IVC. We can also assess if also dilated the internal jugular vein. We can see here the internal jugular vein and the carotid artery. And it was published by the American Society of Cardiography, supporting the general use of evaluation of IVC size and collapsibility in assessment of CVP. The recommendation are that an IVC diameter less than 2.1 that collapse more than 50% with the sniff correlate to a normal CVP pressure of 3 millimeter SCG, range between 0 to 5. This phenomenon may be observed in hypovolemic and distributive shock, which is septic shock is distributive shock. A larger IVC that collapse less than 50%, suggestive high CVP pressure of 15 SCG. This phenomenon may be seen more with cardiogenic and obstructive shock state. We can see in this slide how we can take the measurement of inferior vena cava if less than 0.5 with total collapse, how we can evaluate the central venous pressure from 0 to 5, 1.5 to 2.5 with more than 50% collapse, 6 to 10, 1.5 to 2.5, less than 50 collapse, between 11 to 15, more than 2.5, and less than 50% collapse, 16 to 20 the pressure, and more than 2.5 with no change, more than 20. We can see here it's this view the IVC. This is the left atrium, the right atrium, sorry, and we can see the IVC. And by using M mode, we can see how the change with the breathing and collapsibility. And this one, which is normal, more than 50%. And in the other view, you can see there is no change at all for the sign. Only thing, be careful about when we are taking only IVC assessment may induce sometimes error, because sometimes the IVC is dilated, not only due to fullness of the tank, what we said, could be related to pulmonary hypertension, could be related to PE or chronic lung disease. So be careful about that. We need to associate it with evaluation of the heart and the lung at the same time. We can see this view with dilated IVC, this clip. Okay, now we will continue by doing fast and thoracic ultrasound. We can see fast could be, this is the Morrison pouch, and we can see there is effusion there is free fluid, usually most likely related to hemorrhage. If your patient is hypotensive and you found a large pocket of free fluid in the peritoneum, most likely due to hemorrhagic shock. And here also in the left part. What about the compromise of the tank, pneumothorax? Quickly, I will go. Now, some of the participants of this webinar will ask why we are seeing about pneumothorax in rash, and also could be also interesting for septic shock management. Later, I will mention that. Pneumothorax, we have here, we can see the pleura, and we have what we said A line, it's reverberation of the pleura. And usually we have an horizontal movement of the pleura, what we say the sliding. The idea is the parietal pleura and visceral pleura at on top of each other. And while any person is breathing, it's moving, which is normal. When it's not moving, it's abnormal when we have pneumothorax, and we will not have this movement. And in M mode, we can see here what we say the barcode sign or stratosphere sign to compare with the normal finding here, the seashore sign. I will show it to you in other view. This is in the clip, we can see there is no sliding here. This patient has pneumothorax. There is no sliding, and this patient is the same patient, but I scan him the other side, and we have sliding this horizontal movement. And we can see the what we said, the barcode sign when we are using M mode. Here for this patient, we have like barcode there to compare with the normal finding of seashore sign, patient with no pneumothorax. Other sign when we are scanning the lung, we can see what we said that the B line, or we can say it also lung rocket. It's like this this longitudinal line coming from the pleura from the top to down. This is sign of pulmonary involvement. If it's diffuse and bilateral, it's going with pulmonary edema and overloaded patient. But also if was isolated, could be something else. Could be pneumonia with with interstitial involvement. If the patient has a trauma in this area and localized, could be due to lung contusion. Always we need to integrate what we can see in point of care ultrasound to the clinical view assessment of the patient. We continue about the pipes now to check about the aorta. We can check in different area in suprasternal, parasternal, in the epigastric area, supraumbilical area, and femoral area before bifurcation. In supraumbilical area before bifurcation, then we can check for the femoral vein to check if there is or no DVT in the femoral area and popliteal area. This is the third step. First, the arterial side of the circulatory septum, and secondly, the venous side. We need to avoid, this is something very important, sometimes the risk of ruptures, abdominal, aortic aneurysm. And this is sometime when we can find it in the emergency. And clearly we have severely dilated aorta, Monzar 6. The patient has to go immediately to the OR. And recently, any delay, the patient can die immediately by rupture of aorta. This is something major. We can see if there is a leakage. And if there is obstruction of the pipes, for example, DVT. And to be honest with you, when we find there is DVT, massive DVT, and we will check by evaluating the heart at the beginning, and there is RV strain, most likely we are facing pulmonary embolism, and we have to deal with that as pulmonary embolism. As I mentioned, we need to avoid vascular catastrophe like ruptures AAA. We can see in longitudinal view or in transverse view. And also we can check for DVT. In this view, we can see there is a clot in the femoral vein. But be careful, a clot or hypoechoic material, it's not found always. It's sign of all DVT, mainly more than 2 weeks. Acute DVT, we can't see a clot by ultrasound, but the most important sign is there is complete compressibility of the vein or not. If the vein is completely compressible when we apply pressure, that means this is the major sign of non-DVT. Non-compressible is the major sign of DVT. I will insist, diameter, intramural thrombus, it's direct sign, but it's not found always. But put on your knowledge, this is very important. The most important sign is the incompressibility of the vein. And we can see in this clip, we have here the vein, and we are applying a pressure. It's the vein not compressible. This patient has DVT. And directly after our evaluation of rash, by checking the pump, if the pump is with hypovolemic shock, it's hypercontractile heart, small chamber, flat IVC, we can possibly have abdominal aneurysm or aortic dissection or any hemorrhage. We can find positive FAST. For cardiogenic, we have hypocontractile dilated heart, distended IVC. We can see B-line lung rockets with the bilateral distribution going with pulmonary edema. In obstructive shock, we can find mainly hypercontractile heart, pericardial effusion, cardiac tamponade, RV strain, cardiac thrombus, could be distended IVC or jugular. And if in case of pneumothorax, absent of sliding and seashore sign and barcode sign. In distributic shock, which is the finding what we can see in septic shock. We have hypercontractile heart in early sepsis, hypocontractile in late sepsis. This is what we said in this period, because our assessment is dynamic. We assess the patient at the beginning and we reassess him after giving him prompt management, and we see how he's improving or not. And we can find in a period severely hypocontractile heart, what we said, frozen heart with ejection fraction less than 10. And with prompt management, it's completely reversible, and he can back if he's treated and cured with totally normal heart function. We can, concerning the tank, normal or small IVC in early sepsis. We can find, if the cause is peritonitis, we can find peritoneal fluid in the abdomen or empyema and pleural fluid, pleural effusion. And concerning the pipe, usually no DVT, nothing related to the aorta, should be normal. Shock. Septic shock, hypovolemic shock, cardiogenic shock, bleeding and dehydration. All this shock can be assessed clearly by ultrasound, except intoxication. Sometimes it's difficult. Ultrasound, we are not able to make this diagnosis, but all the others, septic, hypovolemic with bleeding or dehydration, cardiogenic shock with acute coronary syndrome, cardiomyopathy with congestive heart failure or pulmonary embolism, we are able to assess them and to make early diagnosis by using proper ultrasound, point-of-care ultrasound assessment. And this is a very common, it's very common to follow those patients in the emergency and ICU. We can see septic shock, 43% managed in emergency department, 62 in ICU. And we can see maybe more and less for the other cause of shock. We are start with patient shocked. We are doing ABCD, ECG, X-ray, and we will integrate ultrasound to that by doing IVC. Now I'm showing how we can integrate that. We have collapsed IVC, no or minimal variation. We have possibly variable, significant variation, and full lumen, no or minimal variation. The first one, collapse, patient has hypovolemic versus distributive shock. The other patient, which we has a big IVC, non-collapsible, he has most likely cardiogenic shock or tamponade. And the variable lumen, it's undetermined. We need to do more investigation to be sure about that. We can complete our assessment by doing chest ultrasound to check for pleural effusion, abdominal ultrasound to check if there is peritoneal free fluid, AAA. We complete the other one for cardiogenic short heart ultrasound to check if there is LV or RV dysfunction, if there is tamponade, chest ultrasound to check if there is air or fluid in the pleura. And we start the first one, hypovolemic, by fluid challenge, and the other one, reperfusion, obstacle removal, and inotrope support for cardiogenic or shock. When we start by assess also patient, he has history of PE, we did chest X-ray, ECG, we do heart ultrasound, and we check at the beginning the cardiac cavities. If we have normal cavities or reduced with hyperkinesia, and could be related to acute mitral valve of aortic valve, yes, and we can have also pneumothorax, massive pleural effusion, acute MI. We can have hypovolemia, distributive shock. In case of dilated heart, we can be faced of cardiogenic shock, advanced septic shock. It's late stage of septic shock or post-arrest state. And if there is pericardial effusion, we can have RV or RA collapse, cardiac tamponade. We can complete our hypovolemic or distributive shock by chest ultrasound to check if there is air or fluid in the pleura, abdominal, if there is any peritoneal fluid or AAA. We can do for cardiogenic shock vein ultrasound, checking for possible DVT. If we have if we can find pleural effusions, we can use ultrasound for guide pleural drainage. And in the cardiogenic shock, we can continue for reperfusion, other treatment, like for example, if there is DVT. And for cardiac tamponade, also ultrasound guided pericardial drainage. And everything can be assessed we can use also ultrasound guided for central line insertion, guidance for central line. And after evaluating the patient, which kind of shock he's developed, how is his fluid status, we start to stabilize him, giving him fluid. If he need inotrope support, stabilizing blood pressure, airway management. The second step is to identify the potential source of infection. And we can see the different source of infection. The most common could be pneumonia, chest infection, but also intra-abdominal infection, urinary tract, catheter-related infection, miscellaneous site infection. And how ultrasound may help us for that. If we want to check for possible chest infection or pneumonia, we can do, this is after stabilizing the patient because it will take time, do complete lung scan. We can use the 8 zone of lung, what is proposed Volpicelli, with the first aerial, upper anterior, lower anterior, upper posterior and lower posterior to check if there is any abnormality could be related to pneumonia. What sign of pneumonia we may have? B-line, as I mentioned, this is what we said, lung rocket. If it's localized, not bilaterally diffused, it's sign of interstitial involvement. Could be related to pneumonia, could be related to lung contusion, could be, if it's bilateral distribution, diffuse, related to lung edema. But for that reason, it's important when we see B-line to check bilaterally and to integrate that of the patient presentation. What we can also ultrasound, we can detect micro consolidation, we can detect small consolidation, we can detect also macro consolidation, even consolidation of all the lung. Micro consolidation can be like irregularity of the pleural line or minor thickness. We can see also what we said, shred sign. A shred sign is a small localized consolidation. This could be related also, for example, to lung infarction secondary to pulmonary embolism also, and can be related to infection. And we can see micro consolidation, what we say tissue-like sign or hepatized lung. This is a macro consolidation. It can be with or without bronchogram. And also we can find pleural effusion by ultrasound. This is sign, we can see B-line here. Lung rocket, what we said. This is vertical line coming from the pleura from up to down. This sign is sign of pulmonary of interstitial involvement. And now we can speak quickly. I will mention quickly about lung finding with patient presented. It's not our topic, but quickly in few words. Present with COVID-19 with pulmonary involvement. We can see a B line, but not diffused. We can see B matter mixed with A matter, with bilateral diffusion, Schrepp sign, irregularity of pleura, with bilateral distribution. And this is very important for us. Not only we can detect chest infection, viral versus bacterial. If it's bilateral, it's more viral with this distribution. If it's localized, involving one lobe, it's more slightly bacterial, but there is other option, what we have to, other workup we need to do. But this is important also with ultrasound. We can monitor if it's improving or deteriorating. Alveolar consolidation. At the beginning, the lung tissue, if we can see something, it's filled by air. And air, we can see air by ultrasound. That can be collapse, as we say, consolidated, atelectasis, contusion, infarction of malignancy. And now the irregularity of pleural line, we can see here, irregular pleural line. We can compare to other one. This is the Schrepp sign, this pyramidal hypoechogenic, this opacity, small localized, going with a small consolidation in the lung. And tissue lung sign is macro consolidation involving large part of the lung. In the view, it looks like liver. For that reason, we are using also the other term as hepatized lung. This is also tissue-like sign, and we can see here some bronchogram. For assessing intra-abdominal infection, what can be the source? Could be abdominal collection, abscess, could be acute appendicitis, cholecystitis, peritonitis, pyelonephritis. So we will go by abdominal abscess. We can, by scanning the abdomen, find an abscess, and could be useful for us, can be drained by ultrasound guidance, or sometimes need to go to the theater for that. We can know this. If we know the source, also we can optimize our antibiotic treatment also. Concerning appendicitis, we can, it's especially interesting with thin patient, pediatric patient. We can see enlargement of the appendix. It's not always easy for all the patient, but sometimes it's useful. And however, we can start by scanning. If we didn't find and we have suspicion, we may do more investigation like abdominal CT scan. For acute cholecystitis, we can find gallstone, the sign gallstone, sonographic Murphy sign, wall thickening more than 3 millimeters, and pericholecystic fluid, also around. This is the main 3 signs of acute cholecystitis. Other sign what we can find, distended gallbladder and sludge. Peritonitis, the finding, we can find sometimes in, we can find intra-abdominal free fluid, also finding of dilated small bowel loop with wall thickness, pneumoperitoneum, thickness of the antrum abdominal wall. Perforated appendicitis could be one of the most common cause of peritonitis. We can check also if there is an abscess. For acute pyelonephritis, we can assess the post-kidney. We can check about by putting color Doppler to check if it's very shining, and we have clearly symptoms of urinary infection. Could be related to inflammation, inflamed kidney. And also the involved area most likely is hyperechoic, wedge-shaped or round the kidney. It's really specific, associated with sign, flank pain, fever. The urine analysis is positive, going with infection. Also, this is very important concerning necrotizing fasciitis. When we can find cellulitis, if we are checked by ultrasound, it's very important if we can find gas. This is something very important for us, and when we find that, we have to call the surgeon immediately for large debridement. For guide fluid resuscitation, after we can check for the source. After that, how to guide? Always we have the question in septic shock. Giving fluid, how much? When? Fluid challenge, as we know, as per recommendation, to start the resuscitation initial by crystalloid. We can add albumin in septic management, but with ultrasound, how can be helpful for us? We need to check about intravascular peripheral volume, central volume, and extravascular volume. If we have right preload, it's intravascular peripheral volume increase. Left preload for central volume, and pulmonary and peripheral edema if we have extravascular volume. For that, as we mentioned before, when we are doing rush, IVC, it's very useful for us. Intravascular peripheral load reduced with flat IVC, with heart ultrasound, or we can find intravascular peripheral load increase with full IVC by heart ultrasound. Concerning extravascular, we need to do lung scan, and we can see if we have wet lung or we have wet lung with bilateral diffuse B-lines. For example, now we have this view with patient who has IVC totally collapsed with breathing, and this one, no change. This is helpful for us. I will put again this one, how this slide showing before. Also, the size of inferior vena cava may be helpful for us to estimate the central venous pressure. For the fluid status of the patient, we need to do in point of care ultrasound to evaluate that accurately 3 scans, IVC, parasternal lung abscess, and lung ultrasound to check for IVC. Is this IVC is flat or there is change more than 50%, or we have full to check if the patient is dehydrated, need fluid, or patient is overloaded. Parasternal long axis to check the left ventricle. If we have dilated left ventricle, patient most likely can be overloaded. And if we have the left kissing sign, we have a small left ventricle, most likely the patient is dehydrated. And the patient, if he has bilateral diffuse B line, he is most likely overloaded with lung edema. A line, he has dry lung, most likely. This is important because I said for IVCs, we'll take it alone, could be induce us in mistakes, because if the patient has pulmonary hypertension for any reason, pulmonary embolism or pulmonary or chronic lung disease, it will be full and the patient may be dehydrated. Also concerning if we take only the parasternal long axis, we may have dilated left ventricle because the patient has a chronic dilated cardiomyopathy. It will not be accurate alone, but we will mix this 3 items with ultrasound. We are sure to get accurate diagnosis of fluid status of the patient. For example, case number 1, full non-collapsible IVC and no change with respiration. Pulmonary could be fluid overload, as I mentioned, or pulmonary hypertension. We can see completely dilated, there is no change. We can check for patient with dilated hypervolemic heart. And patient bilateral diffuse B line, he has wet lung, could be pulmonary edema. When we mix together full non-collapsible IVC, dilated left ventricle and parasternal long axis and wet lung with bilateral diffuse B line, we know our patient is overloaded and septic shock, and we need to start immediately. No need to give him more fluid. He's already overloaded, and we need to start immediately inotrope, mainly norepinephrine. Other case, patient with collapsible IVC. We can see completely collapsible. And the patient has a small left ventricle completely, the wall of left ventricle and parasternal long axis touching together, what we said, left ventricle kissing sign. And we don't have B line, we have A line, dry lung, there is no B line. So this patient has flat or collapsible IVC, hypovolemic left ventricle with kissing sign, dry lung, A line. We can continue fluid challenge for this patient. This is very important. I think it's the fluid resuscitation. I don't know how I can do it for septic shock patient without ultrasound, to be honest, if we want to do it accurately. Other important application of point of care ultrasound is guidance to enhance safety, to increase the success of bedside procedure. For that, I think I reach the time. I will go quickly because no time to describe all that. We can know for central line will increase the chance of successful cannulation, reduce mechanical infection complication. It's faster, and we have real-time confirmation, and we can identify a quickly complication. It's indicated, and now, and a lot of country in Europe, I think in UK, in France, it's mandatory. We can't do it blindly if ultrasound is available. There is some exception, but usually if ultrasound is available, we need to do it ultrasound guidance. And also now it will come also in King Faisal in our hospital, mandatory to put central line by ultrasound guidance and not by the traditional blind method. We use linear probe, high frequency. For that, we can do it. We have to approach longitudinal or transverse view, short or long axis. We can see immediately the tip of the needle inside of the vein. We can do it for internal jugular vein with short axis and long axis. And we can say it for femoral. We can use it also for thoracocentesis. We may assist R to localize where is there is a large pocket of effusion. We can decrease complications such as pneumothorax. We have successful rate with this ultrasound. We can ultrasound, it's more accurate than X-ray to check about the amount of fluid. We can do it, the technique quickly. We can enter between two ribs to aspirate. We can see two rib shadow, and we can see the tip of the needle going inside, and we can doing the thoracocentesis. Also for paracentesis, the same, increase the successful rate. We can locate even small pocket of fluid, can reduce complications like bowel or bladder injury. You can see here there is large peritoneal effusion. The technique also, it's real-time technique. We can see the needle. Also for ultrasound thoracocentesis, we have three. We can do it by ultrasound guidance. I will go quickly. We have three approaches: subcostal, parasternal, and paraapical approach. For example, this is for subcostal, this one for parasternal approach, and also paraapical. This is a quick summary about what we can do. Patient who has sepsis, we can do echo to check left ventricle contractility, IVC. We can use focal and diffuse interstitial syndrome and lung ultrasound to check if there is consolidation, lung or interstitial syndrome, pleural effusion. We can check hepatobiliary intestinal to check if there is peritonitis, cholecystitis, renal also ultrasound, musculoskeletal, if there is any abscess, neck fascia, gas under the skin, for guidance procedure, and to control the source of infection by drainage, to enhance our procedure, and to make all this diagnosis. For conclusion, point of care ultrasound can enhance safety and increase the success of bedside procedure like central venous cannulation and the drainage and pleural effusion, and can help to individualize management of patients with sepsis and septic shock, and may potentially improve patient outcome. Definitely, and I would like to add something because I forgot to mention. We spoke about pneumothorax, and we will say why pneumothorax, it's not really directly related to septic shock. I agree with that, but also we don't have. I forgot to mention that, but also the majority of the patients with septic shock gonna be intubated and on mechanical ventilation. One of the complications of mechanical ventilation is pneumothorax. But also we can early assess this complication by point of care ultrasound. Thank you very much for your attention.
Thank you, Dr. Hani. Thank you.
Thank you very much, Hani, for this excellent review for the utilization of ultrasound. And I think ultrasound is among the best thing that we have over the years either in emergency department or in critical care. And I think there are a lot of things that we can do, but we have to be trained. I'll start, if you don't mind, with a question. How long does it take to do a rush exam for a patient come with sepsis in the emergency room?
Well, I will give you, this is different. It's different between, it's up to how we are expert on that. But I will give you example. For example, for European Society for Emergency Medicine, if we want to certify when he has to do a proper rash examination with less than 5 minutes, because the time it counts with unstable patient. We don't have to take a long time. So it's very important. The first patient, he's unstable, he's in septic shock. We are doing a quick assessment to clarify which kind of shock, how to start to give a fluid challenge or something else to make accurate diagnosis. And in between, we are resuscitating the patient, giving oxygenation, airway management, fluid, everything. After that, when the patient is stable, we can take all our time to check for the lung if there is consolidation, where's the source of infection. But at the beginning, yes, rush, it's rush. We have to do it quickly within a few minutes. I think the average 5 minutes should be, but definitely not more than 10 minutes.
Okay, so it will not be the management. There are a few questions that we will take, and Carmen, she's asking, what about the benefit of ultrasound visualization to the ICU and how to promote it in the industry of critical care?
I didn't make
the things that how are the benefits of ultrasound visualization to ICU and how to promote it in the industry of critical care?
Well, you can answer to this question like me. It's very important. We can see for ICU physician, it's survival for him to evaluate the fluid status of the patient, to know how we will treat him. And it's powerful clinical tool for that from the beginning. And non-invasive, we can do it repeated as long as we want. Also, for all this procedure we are doing, all the patient in ICU may require a central line or arterial line. We can do it by ultrasound guidance. Definitely, we can check when we give inotrope how the heart is improving, how the heart functions, IVC. It's very important how to promote it, how to develop that. We need to do teaching, to attend the courses, to continue to work about to practicing ultrasound to become effective. But it's very important, I think, for ICU physician and for emergency medicine physician to be familiar with this technology, and clearly it will be useful and your patient will be thankful for you when you will do it. Believe me.
I think I can add whatever you said here in this presentation is true for the ICU. Everything you said that you can do it in the emergency department, it can be done in ICU at different stages. The same principle, the same finding, and the same guidelines is still valid for critical care patients. The other question, will you use TE probe ultrasound examination, or you can only do external phase array to meet the examination need? Do you need to use TE probe, or the usual external array probe will be enough for the examination?
No, external is enough. However, there is some indication for T probe. For example, if you want to make a accurate diagnosis for infective endocarditis, we need to do that. But other ways, no need for a lot of the other application. There is some study and some application that This kind of invasive transesophageal ultrasound could be helpful to when patient is arrested for resuscitation, but still more experimental than that. But for infective endocarditis, definitely by external method, it's not the most accurate.
Okay. A question from another question is, if CVB meets the standard and venous oxygen saturation do not meet that, how to deal with it? So if you have a conflicting reading between the CVB and the SpO2, how to deal with it?
Yeah, it's very interesting question, because the CVP, it's not, we need to check, for example, very simple, what I mentioned, because I forgot to do it, and I did it with the conclusion concerning pneumothorax. For example, you have difficulty with your patient intubated or sedated on mechanical ventilation to reach good oxygen saturation. You need to think about something else, like maybe tense pneumothorax. This is one of the examples. We need to check for other reason why we are not able, because the CVP alone, it's one of our marker for monitoring, but we need to check for others, not only the CVP.
Okay, I think it's very important when you get a patient with sepsis, especially not the early stages, when you start to treat the patient, you give fluid, you start inotrope. Any should not take it alone. You have to combine it with other finding and try to get more information to say where is the patient is. So mostly in many occasions you find conflicting readings, but you have to put everything together and to get more information about your patient. The other question, Dr. Hani, how to find the appendix with ultrasound? Is it located around McBurney point?
Well, all this area in the right lower quadrant, we need to scan it smoothly, to take our time, to go slowly by transverse and longitudinal view. Take our time, many times, from up to down, from external to interior, and we need, to be honest, there is, it's not something easy, and it's not, I think, simple tool. If the patient is very thin, there is no too much gases, and we able to do it. The most important is to take our time and to scan all this area, all the right large our quadrant, and take our time to get it from external to interior to reach the umbilicus, and also to do it also from going with multiple area and multiple layer, and will need time. Take your time, not quickly. I check, as I said, rush should be do quickly, but if you are checking for gallbladder, for appendicitis, take your time and check that, and we can see the view. It's if we saw it one or two times, it's very, very suggestive.
Two questions related to each other. The first question, how to diagnose COVID-19 patient with POCUS compared to chest X-ray, CT scan? Which one have a better diagnosis with COVID-19 in your area?
Yes, we will not diagnose COVID-19 by ultrasound. We can diagnose finding of viral pneumonia. If we want to diagnose COVID-19, we need to do PCR. This is very important. But we can diagnose the pulmonary involvement of COVID-19 very accurately with lung ultrasound. What we can find? We can find usually it's bilateral, diffuse, multiple lesion. We can see a B line, localized B line in some area, in other area A line. What we said, mixed B and A matter. associated, sometimes we can see microconsolidation with irregular pleural line, as we said. Shred sign also is very common in bilateral in multiple area. Microconsolidation with tissue-like sign, it's not common with the patient with COVID-19. It's less common than other. The diffusion bilaterally, this presentation is highly suggestive of viral pneumonia. And when there is epidemic there is outbreak of COVID-19 and the patient present had contact with patient with COVID, was exposed, we can say we can make the diagnosis easily with that.
I think the part which is better ultrasound.
Sorry, Khalid, I would like to add something important. Not only diagnosis, the most important ultrasound, also we can monitor this patient who has COVID-19 or other. We can repeat to scan the lung and to see if this lesion there is some regression improvement or unfortunately increasing by size, by diffusion, by number, and also it's important for us to monitor those patients.
I think one advantage of ultrasound on the CT scan that you can do it bedside and you can repeat the exam in a very short period with no much risk of radiation, risk of mobilizing the patient. So I think an advantage that for, even if we say CT scan is more sensitive, but I think ultrasound is more applicable in this situation. A question regarding the ultrasound: which ultrasound probe are mostly used for the diagnosis of COVID patients, particularly for lung scanning?
Well, I think we have always depend of what we used to do. However, if you want to do scan for the lung with COVID, we don't want to scan only superficial area, like only the pleura. For example, for pneumothorax, we can do it with linear probe. Now, in this hand, we need to go deeper. For that reason, we have two possibilities. We can use the phased array probe. Its advantage, its low frequency, allow us to go deeper. In the same other hand, we can also in the same time scan the heart, because also for COVID-19 patient, we need to give fluid resuscitation and it's helpful for us. This is, it's possible. And also we can do it by curvilinear probe. From my side, I prefer for scanning lung to check for pneumonia, the curvilinear probe. And if I want to scan the heart, I switch to phased array. But both it's possible. For linear probe, it's not accurate. It's not allow us to go deeper, and we can miss some deep lesion.
Okay. A question, I think I will make it related to the presentation, is how the ultrasound will help you to find complication of septic shock.
Yes, a complication of septic shock. For example, what the complication? This is one of the major complications of septic shock is organ dysfunction with refractory hypotension, and it will help us. I think something is very important. The most important, what I insist about, is our decision to start inotrope. I think from my side, or to continue fluid challenge, ultrasound, it's very useful for that. After that complication, I give the example complication, for example, of patient who has mechanical ventilation. One of the common complications is pneumothorax. We can see also we are doing a lot of invasive procedure. By ultrasound, we can check if there is bleeding, intra-abdominal bleeding, if there is pleural effusion, if we, for example, if we insert central line, if there is it was a traumatic, or there is puncture of artery, there is hematoma around. Ultrasound also, we can have early diagnosis of that.
I will add also, I think for kidney function or and acute kidney injury in sepsis, ultrasound will help you to look at the kidney and see the perfusion of the kidney. This is another thing. As you said, Dr. Hani, that the ultrasound will be used in the assessment, diagnosis, follow-up is very dynamic, as mentioned by Dr. Saeed Hashimi, that it helps you to do a continuous process with it. The question, I think, ended by a courtesy question that also for me, when you do a good job with ultrasound and the patient is pregnant, is the baby will give you really a thumb ups that everything is good? Is this a real image?
No, it's not real image. No, it's not real image.
So I think at the end, I will give you a thumbs up for this presentation and trying to integrate this topic in one presentation. Thank you, Dr. Hani, for this. I'm glad to be with you today here, and I leave the floor and the platform for Sean from the webinar organizer, if he has any addition to this. Thank you very much.
Okay, thank you so much. Time is up, I think, because no more questions. So I think we can end up our webinar. I want to thank you again, Dr. Hani, for your great presentation. And also thank you so much, Dr. Khalid, for your kind assistance. Meanwhile, we need to thank all the audiences for staying with us. For more information about ViewSonic forthcoming new webinars or the replay of the previous webinars, please kindly follow ViewSonic official account at Facebook, LinkedIn, or YouTube. Thank you, and see you next time. Bye-bye. Thank you, Doctor.